Well, Alberto, I know you for such a long time. So for me, no introduction needed. For you, probably also no introduction needed. I'm sure he will talk about my favorite delivery system, the liposomes, and we look forward.
Thank you, Gert. Thank you, Gert. Thank you, Beat. Thank you to the organizers of Cleanan for giving me the opportunity to present once more in this interesting meeting. I would like to talk today about drug co-encapsulation in lipid nanoparticles and looking at this as a way of a multimodality approach to cancer therapy. So these are my disclosures. And first, just a general slide to put in a few lines various strategies that we can use in nanomedicine. The first one is the smart delivery of established drugs and tailored products. This is the case of Doxil, as you well know, and which has been a very successful agent delivered in liposomes and which is widely used in the clinic. The second one is to enable delivery of new classes of agents that are very difficult to deliver without a carrier system. This is the case of messenger RNA, as it has been done with the COVID-19 vaccines recently. And we have many other strategies that we can look at in nanomedicine. Targeting to cancer cell receptors, particularly for intracellular delivery. Theranostics, and the previous speakers have already talked about this, and the possibility of getting real-time imaging, molecular imaging, and the use of concomitant therapy along with the information given by these theranostic agents. Co-encapsulation, which I will talk about today, and here we are looking for a synergistic or at least an additive action of multiple agents. And finally, optimizing outcomes of our nanodrugs by combination with other therapeutic modalities such as radiotherapy, mechanotherapeutics, etc. And we are going to give a few examples about it. So the combination that we have been focused on for the last, since 10 years, is combination of an amino bisphosphonate and doxorubicin. And we looked at this combination because we have different mechanisms of action, non-overlapping toxicities between the two agents. And we have a double attack on tumor cells and tumor-infiltrating macrophages by blockade of the farnesyl pyrophosphate synthase. There are immunological effects, which are due to the expression of phosphoantigens induced which can induce then later the activation of gamma delta T lymphocytes. The co-delivery effect, which ensures timely co-exposure to both agents. And finally, we have a very practical purpose for this combination, which is the fact that bisphosphonate ammonium salts can enable remote doxorubicin loading. So this is the schematic view of the loading of doxorubicin into these alendronate containing liposomes. And here you will see comparative cryo-temp pictures. On the right, you will see the doxil liposomes, which show thin and long rods, and often these coffee bean-shaped, these elliptic liposomes. In the case of PLAD, they are spherical liposomes, and the rods are thicker and shorter. And just on the very left, you see PLAD, which is the pegylated liposomal alendronate before loading doxorubicin. Just a few slides, and I will rush through these slides. Pharmacokinetic-wise, the two drugs, doxorubicin and alendronate, and here we used a radio-labeled alendronate molecule with tritium. They are cleared alongside at the same rate when they are co-encapsulated. This is exactly what we are looking for. And when we regard doxorubicin and we compare to PLD, to the doxil formulation, pegylated liposomal doxorubicin, we see that PLAD performs as well in terms, or nearly as well, in terms of the levels of doxorubicin in plasma, and we can have long circulation time, as in the case of Doxil. So PLAD can be considered also a stealth formulation, and in fact, its lipid composition is practically identical to that of Doxil. Here you can see images obtained by Dr. Rafael Torres Martin de Rosales, our colleague at King's College in in London, in King's College London, and who did actually labeling of PLD and PLAD or PLA liposomes. And he's using here either the chelating action of bisphosphonates on indium. In fact, doxorubicin itself is also a good chelator of some of these radionuclides. And what you see is a typical effect of that we have labeled as the EPR effect, and it is well recognized all over. And you can see here that the tumor uptake is really very high, 25% of the injected dose per gram, or 34% even of the injected dose per gram, depending on the tumor model. So this is from the King's College. If you look at numbers, then you can see that in two tumor models, you can see here in the columns of under PLD and PLAD, you see that the tumor levels are very similar for both PLD and PLAD. Perhaps in one of the models, in the sarcoma models, the PLAD levels are slightly higher, but in both cases, they are greatly far superior to the levels obtained with free doxorubicin by about a 10-fold difference. So this is, of course, can create a significant pharmacodynamic advantage for these formulations. We have also studied the anti-tumor effect of liposomal alendronate in vivo with the London King's College group at the Imaging Research Center, led by Dr. Rafael, as I mentioned, Dr. Rafael de Rosales, who did a very elegant experiment in which, as you see here, he labeled, I don't know, no, there is no, unfortunately, I think there is no pointer, so I don't want to waste too much time because there are other speakers, but you have to believe me here that with indium, you label the liposomes and you can see them before 24 hours and 72 hours. You can see that the T looks the same, so the tumor is there at 24 and at 72 hours, expressing actually showing equal levels of liposome localization. However, if you have a metabolic marker, which is what you do here using the technetium-99 marker, you see a terrific drop between the 24-hour to the 72 hours point. So the alendronate also by itself has a significant anti-tumor effect when given in liposomes. There are many therapeutic efficacy experiments in which we have compared the PLAD to PLD, and not in all of them, but in some of them, PLAD is superior to PLD. And actually, it's mainly in the mouse syngeneic models in immunocompetent mice that we see a superior anti-tumor effect for PLAD over PLD. You can see it on the right side for the mouse sarcoma model, on the left side for a mouse breast cancer model. And here in the next slide, I would like to go and show you what can you do with PLAD and radiotherapy. We were interested again in collaboration with Dr. Rafael de Rosales at King's College, and this is actually in one of the medical centers of London, where he did this study with his postdoc, Dr. Amaya Carrasco Minino, who did actually irradiate tumors, and then, as you see here, on day 7, and then he 3 days later, if I'm not mistaken, it's difficult to see from here, but yeah, I can see it from here. He injected the PLAD labeled with indium-111, and as you can see here, you can see the autoradiography, in which you can see on the one hand the non-irradiated tumors that are much larger than the irradiated tumors, but you can see also by autoradiography that the deposition of the liposomes in the irradiated tumors was much greater than in the non-irradiated tumors. In fact, this you can also look quantitatively here in this plot closer to my side, in which you see the red dots are the irradiated tumors and the green dots the non-irradiated tumors. So you can see definitely an advantage in liposome localization. This could happen to many macromolecules and to antibodies, and I urge you to consider also that when we find also some improvement in some immuno-oncology approaches with radiotherapy, it could well be that what we are doing is actually we are improving the delivery of these anti-PD-1 antibodies or other large macromolecules into tumors. So in the next slide, I would like to go more into a study that we did together with Dr. Irene Labec in Texas, who actually used PLAD and Doxil in a mouse sarcoma model and compared the effects on tumor-infiltrating cells. And what she finds here is that by using various markers, she finds, as you see, again, I cannot point, unfortunately, to the slide, but if you look at the green, you can see that the green, which is the M2 population, is very large. In the case of free dox-treated mice, gets a little bit smaller when Doxil is given, and even much smaller with PLAD. Okay, so we are actually manipulating in the proper way, augmenting the M1 antitumoral macrophages with an antitumoral phenotype and reducing the M2, the protumoral. Oh, thank you for bringing this. This is great. Yeah, now I have a way to. I'm not sure that this is going to work, but no, I don't see the. So I think let's go on. I think that. So we'll go to the next slide. And in any case, I need 4 slides. I need this. So another interesting aspect that we saw is that when you look at this plot showing the amount of doxorubicin taken up by the TAM, the tumor-associated macrophages, you see that it is greater with PLAD than with Doxil, and even much more than with free doxorubicin. And these changes are extremely important because TAM compete with TAM are actually, macrophages are the bad guys in the tumor. If you can eliminate them, then you can probably improve the anti-tumor effect. When you look at the indissociated tumor cells, you see that PLAD can actually localizes better than Doxil. You see in the blue dots compared to the green dots, not to the green dots, to the yellow, somewhat yellow dots of Doxil. You can see that the blue dots show you a much greater doxorubicin localization. So to finish up this part, PLAD, this is an experiment that we did comparing the effect of PLAD with and without anti-PD-1. And here you can see at the end of study that you see a significant advantage for the combination of PLAD plus anti-PD-1 over PLD plus anti-PD-1, and definitely also over PLAD. So there is also a synergistic effect with the combination with anti-PD-1. And I will try to show you in a cartoon, in a final slide, why do we think that, among other things, this is happening. And this is one more study that was done with Dr. John Maher, also in London at the Guy's Hospital Cancer Research Center, who did show that when we inject infusions of gamma delta T cells and we give them long with PLAD, we have much smaller tumors, as you can see in the bottom group of mice. As you can see, they have no metastases in the neck, and they have much smaller tumors. The other groups have huge tumors and metastases in the necks. And this shows you the tumor volume, which is the smallest one with a combination of PLAD and gamma delta T cells, as opposed to other groups. So The last experiments I would like to show you are experiments that were done in collaboration with Philos, as we call him, Professor Stylianopoulos from the University of Nicosia in Cyprus, who is an expert in the field of mechanotherapeutics. And as you know, reducing the interstitial fluid pressure and stiffness of tumors allows for better penetration of nanoparticles, as you know, as pioneering works and many studies of the group of Rakesh Jain has shown. And what Philos has found out is that some H1 blocker agents who are mast cell stabilizers, such as ketotifen, can change the mechanical properties of tumors and lead to better therapeutic outcomes of nano-based and antibody-based treatments. And we have collaborated in doing various experiments with Philos in sarcoma models, and I will show one of these experiments. And I think the experiment speaks by itself. The experiment was led by her postdoc, Dr. Antonia Karamboulos, who actually did all the possible combinations of doxil plus ketotifen, doxil plus anti-PD-1, doxil plus ketotifen and anti-PD-1, and the same groups for PLAD and ketotifen and anti-PD-1. And you see here that the best group was the ketotifen plus PLAD plus anti-PD-1 in terms of disease control. In fact, we got 100% of responders in this group, which is really a very nice result for this study. So we think that this multimodality approach is extremely important to consider in the development of nanomedicines. And finally, my last slide, which is really a cartoon slide, in which I would like to show you why do we think that the combination of pharmacoimmunotherapy is important, and why PLAD can play a significant role in this rational multi-pronged attack on cancer. So PLAD can release doxorubicin, which is causing cytotoxicity by direct effect on tumor cells, which release immunogenic cell death signals that are actually recruiting effector cells, T cells and NK cells, to the tumor. And at the same time, the alendronate is suppressing the TAM macrophages, which is actually releasing the brakes that TAM are imposing on CD8 T cells. More than that, the alendronate is also activating the gamma delta T cells through expression of phosphoantigens, which also allows really a concerted attack of gamma delta T cells against the tumor, together with other immune cell effectors. And in addition, the PD-1 blockade, if it is released, then you can have a better attack on these cancer cells. And that, we think, is the way to go, combination, to achieve the best possible results and to make sure that all tumors, and not only a few exclusive, highly immunogenic tumors, such as melanoma, are the great responders. So my conclusion slide and take-home message: repurposing of alendronate in liposomes by co-encapsulation, as I've shown, with a chemotherapeutic agent, gives you a unique mechanism of activity that can improve therapeutic outcomes. And we think that PLAD is projected to replace doxil and free doxorubicin in various tumors, cancer conditions, as indicated here. And drug co-encapsulation is already there. It has been translated successfully to the clinic in AML with the product Vixeos, which has given an additional survival over delivery of standard chemotherapy. And I think it is an attractive tool to boost the nanomedicine pharmacologic advantage. As I say here, more bucks for the bank. So thank you to all my collaborators. I cannot mention their names. Many of these experiments that I have shown, the liposomes were produced in our lab and shipped to these collaborators for those experiments. And finally, a big thank you to all.
Thank you, Alberto. I'm very pleased to see that your long-standing work and energy spent on the clinical development of liposome systems And actually, always with liposome system, with so-called all drugs, and now in particular also the biphosphonate, alendronate, can give such much positive contribution to the patients. At least that's what we hope for. And your attempts are very much appreciated. We will discuss. I have many questions during the next round.